No talking, that sort of thing. If there's questions during the test, of course, raise your hand. I'll come to you. You're more than welcome to ask me any question. I may or may not give you an answer to the question, depending on what it is. I'm not going to tell you what the answer is, but if there's clarification or something you need, I'll be more than happy to help. But once you're finished with the test, whether it takes you 10 minutes or the 2 hours, when you're finished with the test and you turn it in, quietly gather your belongings and leave and go somewhere. I don't care where, but go somewhere. If you decide to congregate out in the hall, I will come out there and tell you to shut up if you're being too loud for the folks that are in here testing. So just be aware of that. We will start the next class on Monday at its normal starting time. So if you're, like I said, if you're done in 10 minutes, and I would be shocked if anybody was, but if you were done in 10 minutes and you wanted to go grab some breakfast, you have more than enough time to go grab something to eat, go wherever, to come back for our next class. I'll say this all again on Monday, just as a reminder, but just to kind of get it out there now so you kind of have an idea what you may be doing just in the interim, waiting for our next class to start. Anyways, this chapter is on principles of infection prevention and control. So there's lots of stuff that we will review, things we will discuss as far as things that are out there in our environment that we have to be protected for, that we have to protect our patients from, and so forth. So 99.9% of this lecture is coming strictly from chapter 4. But I have added just a couple of little items to this, but we will talk about them. So we know we're in a world where there's microorganisms, there's germs, there's things everywhere. We all can say when it's all said and done, yeah, we survived a pandemic, we made it through. Lots of people did not worldwide, but it's things that we need to be aware of. Heaven forbid we ever go through something like that again, but it's things we need to be aware of to lessen the likelihood of an infection spreading somewhere. So these are just a smattering of newspaper articles, magazine covers, news reports, etc. Some of these magazine covers predate COVID-19. Maybe 10, 15, get my math right in my head. Yeah, probably 10, 15 years prior to COVID-19, there was another outbreak that we thought that everybody was worried about, and SARS. Anybody remember the original SARS? You know, that was really the first COVID try, if you will, to spread, and thankfully it was halted pretty quickly. But that began the conversation as far as what should we do to prepare for a potential and an eventual pandemic. So some of the stuff we did really well immediately thereafter. That first novel flu virus, that original SARS, and then things over the years and decades just kind of started to fall by the wayside. And so as a medical community, we kind of got caught when COVID-19 came up. We thought we were prepared for a potential, but obviously we were completely 100% caught off guard. Anyways, I will say this as we go through today's talk. I am not trying to create a room full of germaphobes, okay? I'm not. Need to be aware of, there's times to wash your hands, there's time to be protected, etc. But sometimes we know so much that it affects our being. So I'm not trying to create a whole germaphobe classroom here. You do know I provide and give all kinds of good stuff up here at the front that it's not just for me. You guys are more than welcome to partake and use, which is always funny. Generally after this day's discussion, after this day's discussion, folks tend to start using this a little bit more. That's okay, that's fine. When we run out, I'll go get another one and replace it. If you go to some of the other classrooms, they don't have this stuff. It's because it goes wherever I'm teaching. So sometimes in other semesters, we've been next door, we've been over here. That's fine, that's fine. If I'm gonna be in a new classroom this semester, okay, I'm taking my stuff with me. And it will go and follow me wherever we go, and my students wherever we go. You guys do know you guys aren't the only ones in this room during the semester. So there's other people sitting at your same seat, at your same desk, touching that same table as you. Yes, exactly. So be mindful, and those people, when they come in, they understand you've been sitting in that seat, touching that table. And I'm referring to our second year students that are in here with me too. All right, infection control. Studies estimate that approximately 4% of hospitalized patients in the United States will develop a healthcare associated infection. Will develop a healthcare associated infection. Now, these sort of infections can be categorized generally two different ways. One simply known as a community onset, meaning just being out in the community somewhere, classroom, the grocery store, library, some other location. You came in contact with someone that was sick and you acquired that same illness. Again, how did you acquire it? Community acquired. Just being in an environment where there's others that potentially could have an infectious, contagious illness. Now the term hospital acquired, I think it's obvious where that individual acquired the infection in the hospital. You will also hear the word nosocomial. Those that work in a hospital setting have probably heard that word 1,000 times, but those that haven't, make sure you understand. Nosocomial, that's the fancy word for a hospital acquired infection. And that's the word you tend to hear used most often. Now, isn't it true that somebody could acquire an infection, they're not hospitalized, they're, I guess, technically they're in the community, but they acquired that infection during the course of their medical care or medical treatment. Maybe the patient's not hospitalized, so they're not in a hospital, but maybe they're in a long-term care facility, or maybe they're home, but they're going to an outpatient center for treatment or for therapy, or outpatient center for surgery, minor surgery where they're not going to be admitted to a hospital, they're going to turn around and be sent back home. Couldn't those individuals acquire potentially an infection? Yes, they could. So the term healthcare associated infection would be more likely used for one of those sort of individuals. Wouldn't really call that a nosocomial because they're not in a hospital setting. Trying to reserve that word, or hospital acquired, for someone who's in the hospital setting that acquires an infection. So again, 4% of all hospitalized patients will acquire an infection.
So when like health associated, that would be like I went to the dentist's office and someone was in there with.
Sure, absolutely, absolutely. Again, in the process of your health care, as opposed to community. You and I go hang out somewhere, we go to the movies.
Community would be like a fair or something.
Yeah,
okay.
We go to the movies and somebody there is sick and we end up getting that same thing. And again, we acquired that infection out in the community somewhere. So infection control procedures aim to do three things. Eliminate the source of infectious agents where we can. Create barriers to their transmission and monitor the effectiveness of the control. Infection prevention is everyone's responsibility. Of course, I'm going to say respiratory therapists, and that's true for us, but anybody, it's their responsibility, and especially any healthcare provider, their responsibility to ensure infection control prevention is being practiced. Now, for an infection to spread, there has to be three things. Has to be. We can eliminate one, we will eliminate the spread of an infection. So number one is source of pathogens. You need the bug, you need the germ, you need the microorganism. And again, you've heard me say this before, where should you not be when you're sick? In a hospital, because that's where all the bugs are, that's where all the pathogens are, right? We do know when we're that sick we need to be in a hospital setting. I'm joking when I say that, but again, we know that's where all the germs are. A route of transmission. How is that germ going to get from where it is to you, or wherever it is to the patient? It needs a route of transmission. And then number three, it needs a susceptible host. There's not susceptible hosts in a hospital, are there? There's a ton of them. Think about all those poor patients that are sick and not 100%. There's your susceptible host. Or the people that work in a hospital, us, we could be a potential susceptible host. Again, you stop any one of those locations, you will stop the spread of infection. Get rid of the pathogen, okay, then there's nothing that could be spread. Get rid of the route. Maybe the route is, again, the bugs over there, the germs over there, I go over there, now it's on me, and I see you, my patient, and now it's on you. Eliminate that route, you're not gonna get sick, or my patient's not gonna get sick. I wish I could say, well, just get rid of the susceptible hosts. It's not that easy, right? Not that easy. That's us. Those are our people. That's our patients. So I can't really get rid of them, unfortunately. I'm joking. All right, sources of infectious agents. Humans, us, we are the primary source. We are the primary source. Inanimate objects, contaminated medical equipment, the medical equipment we are using on our patients, medications, linens, bed linens, the pillowcase, the sheets the patient's lying on, high-touch surfaces, that patient call button and call panel, and they control their TV and the volume and the channels and call the nurse and everything else with it. I mean, that thing's been touched umpteen different times. That's a huge source of potential transmission. Bed rails, tray tables, bathrooms, etc. I know all these little things are individually circled. I just say circle the whole damn room. That's where the stuff is, right? And again, I'll share stuff with you guys today, and I don't want to totally gross you out. But things to consider, and these may be things not necessarily that you wouldn't know or understand, but maybe you just haven't thought about. And I'll kind of point to folks that have been in a hospital setting. Ever had a patient that you've seen in a hospital setting, or an individual in a hospital setting, who has friends or family visiting, and maybe they are bringing a child, small child, young child that, you can't hold the child forever, they've got to put them down and they're going to run and do whatever. A child crawl on the floor, lay on the floor. Do you know in a hospital what potentially could be on that floor? Somebody could say, well, didn't housekeeping clean the room beforehand? Of course they did. But someone like us just walked in a room that had who knows what on it on the floor, and I proceed to walk down the hall, and I make a turn, and I turn into that patient's room. Who knows what's on the bottom of our shoes and our feet? Not our feet, our shoes. Yeah, we're not going barefoot. Absolutely, we're not going barefoot. And again, brings up another point. The shoes you wear in the hospital. God bless you. Are you wearing those same shoes when you get home and walking through your house, your carpet, your floor? No. That same shoe you were walking in a hospital? Yeah, in a hospital we wear gloves and we have gowns, and there's even little booties that can go over your shoes, but you're not wearing those 24/7. You're walking wherever you're walking. In a hospital, again, where all the germs, where all the bugs? In the hospital, somewhere they're there, and we're walking all over the place. We turn around, we're done with our day, we get back in our car, we drive home, we get home, we get out, and we start walking through our house. Oh, and there's a small child in our own home who's crawling on the floor in the house where you just walked with your nasty, dirty tennis shoes that you just came from the hospital. Long story short, my opinion for what it's worth, I have my hospital shoes and I have my regular shoes that I wear every other place. But when I get home, those hospital shoes are coming off. They're going to stay in the garage, or they're still somewhere in the house, but I'm not walking all over my house wearing my hospital shoes. Okay, so that may be something to think about. You may have your favorite pair of most comfortable tennis shoes whatsoever. You wear them everywhere, and you're planning on wearing them to the hospital. I would put a little red flag there. Maybe you need to invest in another pair of shoes that you enjoy, that's comfortable, of course, because you're going to be on your feet when you're working in a hospital, but something that you can transition to so you're not wearing your shoes that you've worn in a hospital. Again, emphasizing walking to a hospital, because who knows what's on that floor. And do we walk as respiratory therapists on every floor in every area of a hospital? Yeah, that's one of the things I love about being a therapist is I can go all over. I can see so many different things. I'm not just stuck with the same four walls. but at the same time, we're walking all over. And who knows what we're stepping on and what's adhering to our shoes that you can't just visibly see.
You could really go really deep into that though,
Oh,
because like
absolutely.
you're wearing those shoes, you get into leaving the hospital, get into your car,
Mhm.
leaving particles on the floorboard,
There you go.
and then
Sure.
you wear a different set of shoes.
Sure. Transmission, absolutely, sure. Everybody in here is going to have a thing of Lysol that wherever you're spraying your feet. Like I said, I am not here today to create a room full of germaphobes. Just things to consider, to think about where you've been, where those shoes, bottom of those shoes have been. All right, resistance to infection varies greatly from one person to the next. It could be because of their medical history, what's going on with them right now. You ever had one of those moments or days or times where you've been working too hard, or studying too hard, pulling those all-nighters, physically you're exhausted, maybe you haven't eaten well? You know, what happens to your immunity? It's going to be suppressed, again, because you're not 100%. So things like that could happen to any one of us. No, I'm feeling pretty good right now, but I was up all night studying for that test or doing that assignment that I was trying to catch up on. Worked all day the day before, had very little sleep. Now I'm out there again being exposed. Sure, it's possible. My immune system is not as sharp as it was when I'm 100% on. When I've gotten a good rest, when I've eaten right, I've got a good meal, those sort of things. So, you know, that resistance to infection can vary greatly. Some other things, especially the susceptible hosts. Maybe a poorly controlled diabetic patient. The textbook said increased age, but I will also add to that those that are older and those that are very young. Again, maybe their immunity hasn't been built up really yet. So just not older folks, could be very young folks too, that could be considered more susceptible. HIV, AIDS infection, we know their immunity is going to be hampered because of that virus. Cancer patients, chemotherapy patients, their immune system's going to be down, so they're going to be more susceptible. Just think about it. If I have a cancer / chemo individual with me, we both go into the same area, we're both exposed to the same bug or germ, we both leave, my immune system's probably going to fight it off and kill it, and I'm not going to feel sick. They're going to be so much more susceptible to acquiring that illness and that bug or that germ. Surgical patients. Again, no matter what they're working on, now the patients open up, there's potential for microorganisms to get in. But here's another take on the surgical patient. What if the patients had chest or abdominal surgery? Once the surgery's over, do you think they're going to enjoy deep breathing and coughing?
No.
Absolutely not, and I understand why, because it hurts, right? So those patients are more likely to breathe shallow, not effectively cough to clear their own secretions. And again, if secretions are retained, more likely to develop a pneumonia. I know we've said that before. Devices, medical devices, especially devices that kind of bypass defense mechanisms of the body. For us, think about the breathing tube, the endotracheal tube or a tracheostomy tube. You just bypass that upper airway. Again, I can go off on a tangent about humidification, which I'm not. That's one thing, but again, just the natural defense mechanism of our body. Catheters, IV lines, central lines, anything going into the body that's kind of bypassing the skin or entering the body through the skin, that's just a way for microorganisms to then access the individual and make one sick. Now, of course, sometimes we need an endotracheal tube for a patient, or we need a IV, or we need a urinary catheter for a patient. Again, make sure they're placed properly, make sure they're managed properly. All right, 3 primary modes of transmission. Contact transmission, droplet transmission, and airborne transmission. Those are the 3 major or primary routes of transmission. Now, of the 3, contact transmission is the most common. Droplet and airborne transmission are respiratory passed, again, from breathing, from the air. But going back to contact transmission, of the two types of contact transmission, direct and indirect. Now, direct contact transmission, I promise I can say that. Direct contact transmission, the example would be, I'm sick. You're my patient. I go to take care of you, and I pass my illness to you directly. Direct contact. I'm the source, I'm the sick one, but I came to work anyways, even though I was sick, and now I got a patient sick. That's direct contact transmission. Indirect contact transmission is patient in bed 1 is sick. I am not. I go see patient in bed 1. That microorganism, that germ is now on me. And then I go see the patient in bed 2 across the hall and carry that microorganism to that patient. Again, I wasn't the sick one, it was this other patient in bed 1, but that organism got onto me, and now I went to patient in bed 2 and got that patient sick. Make sense? That indirect, again, we can always say, how did it get on me and how did I pass it? Oh, I forgot to wash my hands. I didn't do hand hygiene, that sort of thing. Something so simple and preventable. Now, like I said, droplet and airborne are respiratory generated microorganisms. Now, the difference between the two, droplet transmission, these respiratory droplets, okay? So when the patient's talking, especially coughing, sneezing, laughing, all that other stuff, that's the larger, emphasizing the word larger particles that can spread through the air for someone to breathe in. Now, typically for droplet transmission, that droplet, even though we might not, clearly if I'm up here talking and spitting and spraying, you can see that. But sometimes these droplets you can't necessarily see with the naked eye because they're still small, but by comparison, they are large enough to potentially spread. Now, droplets traveling a short distance. So I would say if I'm the sick one with some sort of droplet infection, the first row, you guys are in trouble, because that droplet could carry to you and make you sick. If you're on the back row, you're probably safe, because those droplets aren't going to travel very far before they fall and hit the floor. We used to say it's probably around 3 feet where these droplets can travel before they hit the floor, because the droplets are larger in size. So they can travel only so far before gravity grabs hold and pulls it down. That way, if you're at a distance, you're probably not going to be impacted by a droplet transmission. Airborne transmission. Honestly, the only difference is the particle size is much smaller than, say, with a droplet. So the particle size is smaller. My analogy before, like first row, oh, you're in trouble with a droplet transmission from me. Back row, you could be in trouble if I have an airborne illness, airborne virus or bug or bacteria germ, because it could stay suspended in the air a lot longer. Again, we used to give it distance. Droplet was 3 feet or less. Airborne would be a lot further than 3 feet. Since COVID, they kind of changed some of the distances here. And if you remember during COVID, at one point they said 3 feet, and then they said 6 feet, and then they're like, well, hell, we don't know, just be at a distance. Okay, it's fine. We'll just say short distance versus a longer distance. So if I had an airborne microorganism that if I talk, sneeze, cough, whatever, could stay suspended in this room a lot longer. Meaning it's floating around this room and any one of us could inhale it, and okay, now you have that microorganism. As opposed to droplet, it's only going so far and then it's going to fall. There's that splash zone, if you will, for that droplet transmission. So, maintaining a healthy workforce. Ideally in a hospital setting, if we have workers, we want to keep the workers healthy, right? A healthy worker is going to be able to do the job. A sick worker potentially could spread illnesses to the patients who are already compromised or already susceptible. So, you know, if a therapist or a healthcare provider is sick, obviously you have to call out. Don't come in and try to take care of sick patients when you're already sick. If you're running a fever, obviously don't go into work, because again, we talked about that yesterday. Typical fevers mean you must have an infection of some sort. So stay home until you're no longer running a fever. Hand hygiene, again, washing your hands properly, practicing the infection prevention practices with each and every patient. We'll go over those practices in just a minute. Hospitals do provide immunizations, chemotherapeutic agents to help lessen or prevent the spread. You know, influenza vaccine, again, annual vaccine every single year. Best way that we know right now to prohibit the spread of influenza. Again, we're getting to the fall, and then we're going to hit that cough and cold season, where we're going to have lots of patients with respiratory viruses, respiratory issues that again could potentially put any one of us at risk for infection, let alone our susceptible patient who's in the hospital. I think, I can't swear to it, but I think most every hospital today, I think, 99.9% sure, most, if not all hospitals, patient rooms are private. You know, I can't swear to it. There could be places that I'm just not aware of where you have anybody remember the semi-private rooms, which you'd have two patients in a single room separated by a simple curtain. Oh, that's going to keep things from going around the room, right? And that's one major step I think we've done to improve and kind of cut down the potential spread, is every patient gets their own room.
We still have those in our ER.
ER
Yeah,
is a
in
little
ER
bit
there's a lot
different,
of
yeah.
Those are our old rooms.
Right. ERs can be a little bit different, but in a patient who's admitted somewhere in the hospital, generally, like I said, there could be places where, because of
Rural
staffing
hospitals.
issues, they need to double up patients. You know, that's not ideal, but something to always consider, again, to prevent the spread of infection. All right, so eliminating sources of pathogens. This could be something, aside from what we've mentioned already, or we'll mention even further, is keeping the overall environment clean. So housekeeping, every time a patient is discharged, housekeeping coming in, cleaning the room, wiping everything down, taking out the garbage, taking out the trash, doing the floors, changing the linens, all that stuff. That's a big initial step to try to prevent the spread of any sort of infection. Specialized equipment processing, which we'll talk a little bit about here toward the end of this lecture today. But you know, equipment that's going to be reusable equipment, keeping that clean, keeping that properly sanitized. Some words here, again, bold, wink, wink, hint, hint, probably a good reason for some of these words being in bold. Methods to kill bacteria, the word bactericidal, okay? Those methods will kill bacteria. Things that we do to inhibit growth of bacteria, bacteriostatic. Did I say kill bacteria? No, just to inhibit their growth. Things to destroy spores, spirocidal, or things to destroy viruses, virucidal. Again, depending on what we're trying to clean or disinfect or sanitize, could be those different things. So again, wink, wink, hint, hint. If it's in bold, hey, you may want to double check and make sure you're okay with that. Which one kills bacteria, viruses, spores, etc. All right, the term standard precautions. Every single patient interaction we have, we're going to practice standard precautions. That's the simplest, the most effective way we're going to treat every single patient. We used to call it universal precautions, but they decided several years ago to change it up and call it just standard precautions. Which we simply say, simple level of infection control based on the recognition that all blood, bodily fluids, secretions, excretions may contain transmissible infectious agents. Okay, so practicing standard precautions with every single patient. All the time. Using PPE, personal protective equipment. Yes, depends on what we're doing with the patient interaction, the likelihood of blood flying through the air, or mucus flying through the air, sputum flying through the air, again, is going to determine what PPE we will be wearing. So for example, if there's the likelihood of splashes of liquids, you know, obviously maybe some sort of mask, maybe some sort of eye protection, face shield or goggles or something to protect us. Gloves, of course, gowns possible. Like I mentioned before, little booties that can go on your feet. Yeah, there's a chance of lots of fluids flying through the air. Now, everybody's probably hearing this going, oh my God, respiratory, there's fluids flying through the air. It's possible, it's possible. It's not every day, trust me, it's not every day. But when we do suction, we remove mucus, patients can still cough. Maybe that sends some stuff out of, so you gotta get good at bobbing and weaving to avoid that flying mucus sometimes. I'm joking, but it could happen, But we'll talk about that more when we get to those situations. Yeah, we'll talk more when we get to those situations saying, you should have bobbed instead of weaved, you should have moved the other way. All right, what is, and you know the answer to this, what is the number one way to stop the spread of hospital-acquired infections? Hand washing, hand hygiene. Again, the stuff that we get on our hands on a daily basis, we should be washing our hands umpteen different times during the day, right? Anytime we're coming in any sort of interaction, even just general public, we should be well aware. Washing our hands, making sure they're clean and sanitized, because maybe in between those hand washes, am I rubbing my eye, am I touching my face, all those bad habits that we all have. Now you have that transmissible. Thanks, Jerry. You all have, and I need some new one, I'm getting kind of low on that. All those things are potential transmissible ways to be on a patient. So practice hand hygiene before and after every single patient. Okay? Doesn't matter what we're coming in contact with. You may be walking in the room thinking you're not going to touch anything, and the second you're in the room, now you got to pick something up, or the patient asking you, can you hand me this or do this? Even though you thought you were just going to walk in the room to look to see if they were on oxygen or not. And yep, they're on oxygen. Okay, thank you. And you're out the door. No, they need you for something. So always make sure you're entering that patient environment. You've washed your hands before, and you wash your hands when you leave, before going on and doing the next thing or the next task. Steps for hand washing, again, stole what they had here in the book about washing your hands. I will point out things we sometimes forget about. Your wrists, forearms. Make sure, obviously, we're scrubbing the palms, the back of our hands, between our fingers, cuticles, nails. What if you have jewelry? When you wash your hands, is it gonna get under that ring or under that jewelry? So no, it may be something that you wanna take off. But, be careful. How many times have somebody taken off a ring, washed their hands, oh, what, you need me? Okay. And you left your stuff there. I would not want anybody to lose a valuable piece of jewelry, wedding ring, those sort of things, by following my instruction and taking it off beforehand. So just be very careful. That thing, if you do take it off, it's not going far, and you're not going to forget and leave it there on the counter or in the bathroom, those sort of things. We're not done yet washing our hands. Washing around the cuticles, drying our hands with a clean towel. You know, back in the day, and they still have them, those air dryers, because it was supposed to save the planet. I need a towel. I need a paper towel that I can dry my hands with and dispose of it. When we're finished, again, the water is still running, right? I'm drying my hands. Water is still running. I should take that towel and turn the water off that way. Those automatic sinks, great, fantastic. That know when I'm there, but generally those automatic sinks, somebody's programmed them to have the water trickle for about 4 or 5 seconds. And the men's restroom over here, I'll press that thing, trying to hurry and wash my hand before it cuts out. Actually, they've actually done a better job. They actually have recently adjusted it, but it used to be one of those really 4-second things. I probably hit that thing 5 times
Bird bath.
just washing my hand. Speaking of which, and again, I'm going to say it umpteen times today, not trying to create a room full of germaphobes, but when somebody else, not me and you, somebody else goes and uses that restroom today, they go in there, they do their business, whatever their business is, all right? Do you think there's people, nobody in this room, I know that, but somebody else that doesn't wash their hands after using the restroom? How disgusting is that, right? But there's people that do that, right? I said do. Did you get that? It's an analogy. All right, so there's people that do that. That same person was in that restroom, that public restroom that you just went in. They were in there just before you. They did their business. They did not wash their hands. They exited that bathroom.
Touch the door handles.
They touched the doorknob or the door handle, because isn't it kind of peculiar that most restrooms open inward, so you have to pull the door handle to exit? That person before you, with who knows what potentially on their hands, grabbed that doorknob or that door handle, opened up. They left. 3 minutes later, you enter that bathroom. You do your business. You go and you do a very thorough, perfect, textbook hand washing. Your hands are now clean. Excellent. You leave that restroom. You grab that same door handle, open it up, and walk out thinking your hands are clean.
Is that why is that why the trash can is right there at the second door?
Absolutely, Chad,
Because
that's why
you're
that
on this
trash
floor and you're right there? Because I went to another bathroom on the first floor and I'm like, where's the hell's the trash can?
I can't speak for the ladies' room because I've never once stepped foot in the ladies' room here. But if you walk into the men's restroom, you walk into the restroom, you wash your hands, you dry your hands with a paper towel, and you look for the trash can, there is no trash can in the men's restroom.
Nope.
Because you have to actually walk out. There's 2 doors. And using that paper towel, you're opening the door, opening the outer door, and you drop it because the trash can is right there by the door.
I appreciate that.
Every time they move that back into the bathroom, I'm like, no, it's not. It's going on right here. And I think sometimes people get frustrated, and I understand. They get frustrated, there's no damn trash can, and somebody will be a slob and just throw their paper towel on the floor. They just walk out, they will see that trash can right out the inner, or right inside the inner door.
Corridor.
I think what needs to be more standardized is like I've seen it in very few places. One of them being Winn-Dixie. Like they had like a little especially in the height of COVID, they had like a little foot thing.
Yep.
On it. Just
Use
use
that
it
to open. Yes, absolutely. So, so technology, I guess I call it technology, or just people, innovative ideas that are coming up to have better ways so people don't have to touch that door handle. Or I'll bump into the automatic handicap thing and
Well, since
doors open on its
they
own.
have those, but when those came out too, they then had door handles that were made where they were kind of like a hook, and you could like
Yeah.
grab with your arm and
something.
pull.
Right. And again, all those are just steps to try to help to prevent what we just were describing. Now you're going to be afraid to go use any public restroom. All right. What's a wonderful invention, and I can honestly say I remember when these things first started appearing in a hospital. The hand gels, the foams, the hand sanitizers, they're all over the place now, right? Everywhere. If you look inside my truck, I probably got 3 of them right there. Just so when one runs out, I throw it away and just use the other one. No matter where I go, I know I have that hand sanitizer. In a hospital, they're outside of every single patient room. They're inside of every single patient room. They're all over the place, which is great. You have hand sanitizer. You can kind of rub it, scrub it all over your hands, and do a pretty good job decontaminating your hands. So, convenient and effective, but it doesn't work with every single germ we potentially could come in contact with. Now, inside of a hospital, probably the biggest one we encounter is the bacterium, what we call C. diff, Clostridium difficile. It's more of a GI issue, and so things are coming out the page. Those that are in the hospital definitely know what I'm talking about. Kind of a GI issue, which respiratory, we don't work with GI stuff. We work above the waist, right? But it's a very nasty infection where they will have some severe diarrhea and We talked color yesterday with sputum. Sometimes that's very colorful and very smelly, and I can't wait to get out of the room as fast as I can. Or I'll come back and see that patient. Let me go on to the next patient, let that air clear a little bit. But those patients that have that infection, if you say, well, I'll just, again, I'm foaming in and I'm foaming out after, which I get, that's fine. But if you happen to have some of that C. diff microorganism on your hands, that hand sanitizer will not kill it. Will not kill it. And so what's the best, what do you do? Soap and water. Soap and water. And I will still say, and I will say on till I'm dead and gone, nothing beats good old-fashioned washing your hands with soap and water, right? I still will use the hand sanitizer, obviously. But soap and water, soap and water, soap and water. Don't forget that, the basics. That's never gonna go away. There's some verbiage, I didn't include it here, but some verbiage sometimes they'll say when you're not supposed to use this stuff. Obviously C. diff is when, it's not gonna be effective, wash your hands. Another thing they always say is if your hands are visibly soiled, if my hands are visibly soiled, I'm not gonna smear it with hand sanitizer and think I've done a good job preventing the spread of infection. I'm going to the sink and using good old-fashioned soap and water for probably how long? Half hour I'm scrubbing my hands, right? And that's something I forgot to mention. Back here with hand washing. How long should we wash our hands for? How long?
Twice.
Say your ABCs twice. Okay. How much time is that? I'm looking for a number.
20 seconds?
20 seconds? Okay, I like that. Your textbook, your Egan Fundamentals of Respiratory Care textbook uses the time 15 seconds. I, however, I know you'll be surprised, I, however, prefer to focus on the CDC's recommendation of 20 seconds. So your textbook says 15 seconds. I can't change the textbook. But Centers for Disease Control recommend 20 seconds of vigorous hand washing. So I'm gonna go with that. I'm gonna say 20 seconds. If you prefer 30 seconds, then more power to you. And no harm, no foul. But I would say minimum.
So if
20
you was gonna
seconds.
have that on a test, you're gonna put 20 or are you gonna put what the
That's
book
a
says?
great question, Chad. If I reference the Centers for Disease Control, the CDC, 20 seconds. If I say according to your Egan textbook, 15. But
Are you gonna do that to us?
would I do that?
Well,
too?
those two questions.
Would I do that? Twice?
Those two, yeah.
You're worried which one I'm gonna put. She wants both of them.
Yeah.
Where 15 and
Would
20
that
would be
an
available
answer
answered
where both
options.
answers can be right?
That's one of those where both answers potentially could be right. Unless I said
Specifically,
your textbook, Egan textbook, or
Or
specifically
CDC.
the CDC. Make sure, 20 seconds for the CDC. Sorry, totally slipped past me. Also with sometimes these alcohol foam sanitizers, they dry so quickly that sometimes you might not have an opportunity to get all parts and areas of your hands and wrists. Again, never hurts to grab a little bit more. I know many times we might not know how quickly some of those things are gonna dry, and used a foam and it seemed to last pretty good, or didn't last long enough, and the next thing you know there's a liquid sanitizer, you really goop it up and you're like, oh my God, it's splashing and spraying all over the place. So it never hurts if you need a second go around at it, but just make sure that at the very least we are using it. Still, of course, soap and water, hand washing, but I can still. And so if you were to follow me in a hospital, John washes his hands really good for 20 seconds. I go into the room, the second I knock on the door, I'm already foaming, I'm already talking to the patient, I'm already doing one of these. Now I put my gloves on, now I do whatever I gotta do, okay, wrapping up, okay, throwing the gloves away, foaming again, and then I'm back to the sink. Thankfully my hands don't dry out very well, or don't dry out easily, but sometimes having lotion, because your hands can dry out, especially the alcohol can really dry out your hands. All right, gloves. Speaking of gloves, gloves are vitally important. Protect both the patients and us, the healthcare workers. Now, there's such a thing as clean gloves. Those are the gloves that are in the boxes that when we enter a room, we just go grab a pair out of that box and put it on and begin working with our patient. There's also sterile gloves that come either as an individual glove or an individual pair of gloves in a single package. Now, if we're performing a sterile procedure, I can't just use the gloves out of the box. I need the sterile gloves that are in that package. Or when I open up that package, it's just either a single glove or the pair of gloves that I put on. Because what I'm about to do to the patient is a sterile procedure. We do perform some sterile procedures in respiratory care where we have to put on sterile gloves and not just use the clean gloves that are there at the door. We'll go over how to put those on, because if I don't put those sterile gloves on correctly, I can have just contaminated that sterile glove when the glove itself is supposed to remain sterile. So we'll go over in the lab steps on how to put on sterile gloves so you maintain the sterile environment that you're in. But the non-sterile gloves, again, those clean gloves that are there in the boxes, those are what we're going to use for general routine care. Now there could be times, and I'll show you guys do this. Again, it's habit. I put on those non-sterile gloves, those clean gloves, when I enter any patient's room. And I'm about to do a sterile procedure. I can still put those sterile gloves on over my non-sterile gloves. Do whatever I need, because again, the gloves are sterile. And when I'm done with the procedure, I can take the sterile gloves off, throw them in the trash, and I still have the gloves that were on underneath. So I still can do that. Hand hygiene should be done before and after. Before and after putting on those gloves. Donning is the fancy word that we use in infection control. Donning the glove, but putting on the gloves before and after. And the glove should never be used as a substitute for hand hygiene. I don't have to wash my hands because I got gloves on. Absolutely, that's disgusting. Absolutely not. You're still gonna wash your hands, use the foams before and after.
Like what I use when I'm like cleaning a patient up, for example, a double glove or even triple glove, depending
Yeah,
on.
that's fine.
That way, put the gloves on, clean them up, and then take the dirty ones off, grab the fresh one, and put it underneath them.
Yep, absolutely, absolutely. Another thing to consider, and again, it's one of those things. If I didn't say it, somebody might not completely understand this. Okay. Give you a scenario. I'm going in to take care of several patients today. So I got patients in beds 1 through 5. And so I put my gloves on, I wash my hands, I put gloves on, I go see the patient in bed 1. Do whatever I need to do to patient in bed 1. I turn around and I leave patient in bed 1, I keep my gloves on and I go to patient in bed 2. I do whatever I need to patient in bed 2. I leave bed 2, I go to bed 3, I still keep those same gloves on. Is that what we're talking about when we're trying to protect patients? You're thinking of yourself and yourself alone. Well, I'm protected, nothing's gonna get me because I have gloves on. Yes, but you're potentially carrying any microorganism from patient 1 to patient 2 to patient 3 and so forth. So you may think, well, we should go through a lot of gloves on a daily basis. Yeah, we do. One of the first things that we ran out of during the COVID pandemic? Gloves. Gloves. And we thought we were prepared with some backup, some extra cases, extra storage. We burned through those so fast in the pandemic. Again, shows us we weren't as prepared as we thought we were with having an extra supply. Not expecting that pandemic to be worldwide. We've dealt with natural disasters before in individual areas where people from the non-disaster area could come in and help and provide assistance, and if it was PPE, we could provide extra PPE, but when it was happening to everybody, now the supplies went very, very quick. Sorry, Jeremy.
I had this one time when this guy came into urgent care. He had gloves on before he came in. He took out everything, went to the bag, and he was done. He went to the bathroom. He came out to leave. He was wearing the same pair of gloves. Yeah. And like there was this video that this one lady made during the height of the pandemic, who's like a nurse, and she like simulated like cross contamination using like paint.
Yeah.
And
because it could be everywhere.
Yeah, because people would like go in a grocery store with gloves on, but they wouldn't change them out every time they touch something. So it's kind of something like, well, you're touching this, and you're touching this, and you're touching your phone, and your kid,
yes,
and everything,
yes.
your door handle, your steering wheel.
All that stuff. So easy to spread. In the height of the pandemic, when PPE was, needed everywhere, You know, I told you the story about local hospitals reaching out to us to borrow our ventilators. They did the same thing with our PPE. They said, FSCJ, how many gloves, how many masks, how many gowns can you guys spare? We have gloves and masks and gowns in our lab, but nowhere are we expecting to treat hundreds of patients. We have enough so in a year, in a semester, we can do activities that require us to put on that stuff, but nowhere do we have enough. We of course shared whatever we had, and I'm sure they went through that in like half a day, just what we had. And the other programs, the nursing program, they shared, and other programs, but again, we were that much in need of PPE.
So during COVID, like with y'all, or reaching out, trying to get stuff, my family, we have a farm and we grow chickens. So we wear N95 masks when we're working in the chicken houses.
Yeah.
So shortage in those for all chicken farmers. And a lot of farmers now have issues already
Because they
couldn't get masks.
Right, yeah, oh yeah, absolutely, absolutely. And we'll get to those type of situations later. That's interesting, we'll have to talk about that. All right, so masks, protecting mucosal surfaces against splashes or sprays, not to be confused with the N95 like Chad just mentioned, or a high-level respirator. Mask can be used when we're just trying to prevent that droplet spread. Sometimes masks can also have a face shield on them to protect so nothing gets into our eyes. The N95 or higher level respirator used for airborne spread illnesses. You know, so remember airborne, those are those very small particles that could stay suspended in the air a lot longer, not to be confused with droplet that go out and then kind of fall fairly quickly. Gowns, again, to provide simply a barrier from whatever the infectious particles could be getting on our skin, getting on our clothing. So the cart that's on the left, now it's not always going to necessarily be a yellow cart, but every hospital does have what we call isolation carts, where isolation equipment will be kept, stored. Gloves, masks, gowns, they'll all be found inside those carts. When you begin your tours or your experiences in the hospital, you're going to come across an area where a floor or unit has none of those gowns outside of any patient's room. That's great. Those patients are probably not under any sort of isolation precautions. You come back the next day, and that same floor, now you see 4 or 5 of these carts outside of every patient's room. Kind of lets us know those patients are infectious. Now, if it was the same patient, now they're infectious. And sometimes that's the bad luck we run into. We were taking care of that patient yesterday, didn't take any additional precautions aside from standard precautions, and then we come to find out, oh no, they're under said isolation precaution where we're supposed to wear a gown or a mask or an N95 mask. And I was just working with that patient all day yesterday, and now they've come down with whatever, or we found out they have whatever sort of illness. This picture here, again, I put it in here just as a reminder for myself to say something about this to you guys. So you can see here, they're loaded up, even the hair bonnets, the little shoe protection, the gowns, gloves, masks. I guess the only thing they're lacking is any sort of face shield or goggles or eye protection. But I say this because, again, things that have happened with our students in years past, I want to make sure I should have been clear about that when we were having this discussion. So let me go ahead and say this. You have an isolation patient, okay? This cart is outside of the patient's room. There's a sign on the door as far as the precautions that need to be taken for this patient. So you haven't entered the room yet, so you realize based on the precaution the patient is under that you need to dress up like this, okay? So you're wearing masks, gloves, gowns, everything else. And as you're about to enter the patient's room, you realize, oh, I forgot to get something. Let me go find John. John's just around the corner with some other of my classmates. And you start prancing your way down the hall, dressed like this. You cross through the nurse's station. John, you know, you're all dressed like I just described. People are gonna look at you like you've lost your mind.
Mm-hmm.
They don't know that you have not entered a patient's room. They think you have just come from an isolation room that required said precautions, and now you're walking down the hallway, down the floor, through the nurse's station, carrying whatever potentially that patient had somewhere on your person. You know, they probably would come to me and say, don't let them back here. And I'm gonna tell you, you have to go home because they're not gonna let you come back to this unit. Reason being, because again, they think you were in a patient's room. So let's do the story again. You've gotten all gowned up, you're ready to enter the patient's room, you forgot something, you need something. Got a question even. All right, well, what am I gonna do? I'm taking everything off. It's okay, I know it seems wasteful, but it's okay. Take everything off, dispose of it in the trash, go get the equipment, go ask the question, go get whatever you need, and then come back and then get dressed up again, and then enter the patient's room. Because when you leave the patient's room, you are taking all this precaution stuff off and leaving it there, leaving it in the patient's room as you're exiting the door. And then immediately go and find a sink to wash your hands, right? Just don't go marching through, because I've had, it's happened more than once. Students, and again, they were innocent, I know, they didn't know any better, but they start walking all over the place all dressed like this. No, leave that stuff behind. But I didn't enter the room. I said, I know, but everybody else doesn't know that. Just take it off, go get what you need to get, come back and get regowned. And again, get a new gown. We're not under COVID right now where we're trying to save and reuse PPE. That's a whole other story. I'll save it for another day. But it's okay. We'll get new stuff. So just dispose of what you have. All right, cough etiquette. Again, they teach our patients, ourselves, the employees, the visitors, because, and forgive me here, this picture, he's actually sneezing, but coughing, you could kind of tell it's gonna be the same thing. There is gonna be particle spray when one coughs. I'd have to look up the miles per hour, but
like
obviously
100 or
it
something
comes
like that.
out, yeah, I wanna say 100 as well. Cough maybe is like 50 miles an hour or something like that, but again, it just depends how strong the cough is. But an aerosol spray. And so if I was to sneeze here and I do one of these, guess what? Yeah, front row, you're a splash zone, watch out, I'm sorry. Post signs as reminders. Again, I don't think we need the reminder, but the visitors do, because sometimes you're gonna have visitors do that. You know, they sneeze and they don't even cover up their sneeze. You know, here, take a tissue, sneeze into that the next time, nothing else.
It says 50 to 60 miles per hour.
There you go, there you go. You know, if we were to cough or sneeze, again, back when I was first taught etiquette that if I was to cough or sneeze, obviously cover your cough. How was I taught back in the day? To sneeze, cough into your hand. And so if I was to oh, hey Jeremy, nice to meet you. Let me shake your hand. You know, probably not a good thing. That's why we'll kind of cough or sneeze into our elbow if I can't get any place else. I can't get a tissue to kind of cover my nose to sneeze. I could still do this, right? Practicing hand hygiene after contact with respiratory secretions, even our own respiratory secretions. The term spatial separation, again, kind of gets back to that 3-foot range, that if we have folks with known respiratory infections, picture a waiting room, an ER waiting room, or a pulmonologist waiting room. And if it's a waiting room like the waiting rooms I'm used to, everybody's sitting right next to each other. And you don't want to sit next to this guy, but it's the only seat left, so you sit down and he's coughing and sneezing, like, oh my God, don't breathe. You know, so if you notice today, I think physicians' offices especially are trying to do a little bit better job of spreading the chairs apart, trying to create some sort of distance in case someone does have a respiratory infection of some sort, to keep that distance from spreading. We know during COVID when we stood in lines and they had things marked on the floor to represent what, 6 feet? Because they were trying to say, okay, let's go beyond the 3 feet. Let's do that 6 feet. I remember during COVID, one of the first times we really, myself and my family, one of the really first times we really truly got out of the house, just because getting kind of cabin fever in there, just let's get out. We had, my family, had the bright idea, let's go see Buc-ee's. We hadn't been to Buc-ee's yet. my family. My wife is a respiratory therapist. Her and the boys are ahead of me, and they walk in, and it's as Bucky's as always. And I remember kind of stopping at the door going, oh my God. Oh my breath.
Oh, y'all didn't have masks on?
I'm sure we did, but the masks at that time were not the N95 because there was the run. You know, we still had our cloth mask that I think it's a barrier. It was better than nothing,
Yeah.
but I don't think it's anything special. Yeah, the old cloth mask. I remember somebody made. We had at one point, or we had bandanas, and I said we look like we're going in to rob the place. We all had bandanas on. But yeah, it was Bucky's, and that was fair. But this was the bright idea we had during a respiratory infection pandemic to go to Bucky's.
I was in a situation recently at work where, you know, some visitors came to visit one of my patients, and they saw like one of those isolation signs. I think it was like a droplet one for the flu. So they asked me what she had, you know, they had the flu, so, you know, put the mask on. And then one of the nurses heard me tell them, and they told me I'm really not supposed to tell them that. And I was like, as far as like HIPAA goes,
Right.
like,
Yeah, that's a fine line. That's a fine
do
line.
they have the right to know what they're walking into, or do they just kind of like enter at your own risk? You don't.
You need to
know?
wear a mask. You need to wear a mask when you're in this room, without going into specifics as far as what they had, because they could have anything. But here, you need to wear this mask before you enter this room. Period, and you don't have to get into any sort of details of the who, what, why, and where type thing. You know, when you're in this room, you need to wear this mask, not this other mask. This specific mask. All right, so we know the three primary ways of transmission: contact, droplet, and airborne. So just with that same verbiage, those are the precautions we will place a patient under if they have a particular infectious agent. So, start with the first one, contact. Again, contact. Remember, there's terms indirect and direct contact. Coming in contact with that person. Gloves, and I say this, gloves are true for any contact, because that's part of standard precautions, right? So gloves are always going to be there, so never shy away from saying, well, gloves aren't necessary here. No, you're always going to wear gloves. That's part of standard precautions. But with contact precautions, you must have a gown on. You must have a gown on. Entering the patient's room, you don't think you're going to be doing anything, you have to wear a gown. Okay, because you don't know what, I may touch the bedside table and touch myself, and maybe that microorganism was on that bedside table, and now it's on my gown and not me personally. C. diff, which is probably one of the most often seen contact precautions. Always make sure. Yeah, MRSA is another one, but always make sure you're wearing that gown. Gloves still, that's part of standard precautions, but make sure you're wearing that gown. Mask, eye protection, not necessary. The only exception to the rule is if now there's potential for airborne stuff flying through the air, then using standard precautions in addition, I could still add that stuff to it. But generally speaking, a mask would not be necessary here in this situation, but definitely the gown.
For C. diff, probably.
Again, it depends.
No, I mean just joking.
Yeah.
Because of the smell. So
Okay,
you probably
okay,
want a
yes.
double mask.
There you go, there you go. And something under your nose to kind of
Yeah,
And
because
if
it
it
mute
means-
the smell,
it
yes.
means-
Yes, I'm sorry, yes. Yeah, it's, and I don't want to gross anybody out. You're probably already grossed out enough by some of the things I've said. Sometimes you will go home and you will I smell it. It can't be on me, can it? No, it's not on me, but it does get there. We're like, I just caught a whiff of that.
It's
C. diff
embedded in your
patient
nose hairs.
that I worked with before.
I've taken Vicks Vapor Rub, like
Yeah.
smelling salts before with
Right.
extreme.
And like I said, for us as respiratory therapists, for the C. diff patients, we could say, yo, I got like 6 patients to see. I'm going to go ahead and take the next one, and I'll circle back and take care of that one once the staff is finished with cleaning or doing whatever they need to do for that particular patient. All right, droplet precautions. All right, so used for patients with presumed, you don't know that they actually have, but presumed or confirmed infection with organisms that are spread via the droplet route, such as influenza, the seasonal flu. We will be getting to the point, by the time you guys enter clinicals and start kind of doing your rotations this semester, flu season, cough and cold season's gonna hit, flu season's gonna be present. Into the next semester, you're gonna start seeing lots of patients under droplet precautions, where probably 7 out of 10 of them are due to the influenza. Mumps, rubella are also spread that way, so still through the air, but the particle size, the droplet size is large, doesn't go very far before it falls to the ground. So a standard mask would be appropriate here. So anything that can cause the patient to cough, yeah, we go in and have the patient cough all the time. Sneeze, suction them, doing bronchoscopies, inducing a cough for a sputum specimen. Again, those things definitely make sure we're wearing a mask with. And again, I say surgical mask, your standard run-of-the-mill mask. Not that old cloth mask that I was using when we were just starting COVID-19, but a general surgical mask, similar to what these folks are wearing. Now, airborne
That's
isolation.
an addition, correct?
I'm sorry?
That's an addition to a gown, correct?
Gown's not necessary.
Oh, okay.
Gown would not be necessary here for droplet. Again, if you choose to add a gown to this, it's because things are flying through the air, you don't want them on you. You can still add a gown, and I'd say that's using the standard precaution, right? But the primary thing for droplet is that mask, Airborne isolation, again, to reduce the risk of that very small particle that if the patient was to exhale it, cough it, sneeze it, it's gonna stay suspended in the air for a lot longer than any sort of droplet particle. Tuberculosis, that M stands for Mycobacterium tuberculosis, the actual organism, but tuberculosis, measles, varicella. What's varicella? The chicken pox. Again, those are airborne spread microorganisms. And so they would require a mask, but a better mask than just that standard surgical mask. So here's an N95. N95, it gives that title because it filters 95% of the particles that are being spread. We can even use a respirator. Looks like you're getting ready to paint your walls or paint the house, right? That would be also acceptable in this sort of situation.
And then at our hospital, like for the guys who have
Mhm.
beards,
Mhm.
and those that wouldn't create a seal, they have like a hole over the head
The
thing.
little
with
helmet
the,
like
you would
thing.
look like you're that, like those people from Monsters Inc. Like the 2319.
You're right. You're ready to go to outer space. Yeah,
Yeah,
got the
basically.
spacesuit. Proper fitting is required. Like Jeremy said, guys with beards, sometimes the seal isn't good, so proper fitting would be required for an N95 mask. I don't have to be properly fitted for just a regular surgical mask, but an N95 mask, I have to be properly fitted to know what size is necessary for me to have that maximum protection. Terry, did you have a question?
Have you ever heard of a patient being exposed to TB vaginally? So we had somebody that came in one time.
Both of us.
I've been waiting to ask because I was waiting for you to get this point, but she was exposed to TB. She got swabbed and she was
I
positive.
gotcha.
So
That's
I'm not trying to be like all
No,
over
I
the
know,
business, but could it have been that they, accidentally coughed or sneezed down there and exposed her to her?
That's it. I'd have to do some research on that one to find out. But tuberculosis, when it spreads, like as someone with a cancer, where a cancer could spread and disseminate to other parts of the body, tuberculosis can do the same.
That's what I was thinking. I'm
And
like,
so originated perhaps, and I don't know the story or situation, but perhaps originated in the lung, not treated, spread to other organs, and maybe that's where one of the locations where it ended up. I'd have to do some research, to be honest with you.
Like she
on
coughed in her
that.
hand and used the bathroom.
Say that again.
maybe. She said, she brought it up, she was like, yeah, they asked her questions, cause she didn't speak English.
I gotcha.
And she was saying, first they said an STD, and I'm like, tuberculosis ain't an STD.
No, yeah,
She was like, yeah,
gotcha.
It traveled through the bloodstream.
I'm like, girl.
From the
you got
lungs.
this?
Right, but originating in the lungs, but spread, and like I said, it could disseminate and spread to other areas, but that's where it may have additionally spread to. Interesting. You find out all kinds of things every single day. Learn something new every single day. let me say this, the right way, we'll always talk about the right way to do this, and with any PPE, but including the N95 mask, it's a single time use. Single time use. When you're done using it, you're finished with the patient's room, you're to remove it and dispose of it. We're not throwing this thing away, but the N95 mask we dispose of. So that's what it says here, using it one time. Because what happened during COVID, again, I can't say what we did was right, but it's what we had to do in the situation we were presented with. We were reusing those N95 masks. You know, they're never intended to be reused. And
Ziploc baggie, put your name
right,
on it.
put your name on it and just use it the next time. Again, that's not how we originally were taught to use that stuff, but again, based on it's either that or nothing, or John's old cloth mask that probably couldn't help anything.
They're not supposed to be reused, right?
Correct, they're not supposed to be reused. So the stuff you'll hear that, hey, we had to do this during COVID, again, it was what they had to do at that time. And still, it's hard, because you know in your heart, you know, this is not right. This is not how we were supposed to do this, but either you save it or you won't have it for the next patient that you have to go see. So really scary stuff. Placing patient in single patient room equipped with special air handling. Again, this is for airborne, not droplet, airborne.
Negative pressure.
Those negative pressure rooms. So for example, in this room right now, air enters, air is being recirculated back and forth, right? Inside this room, AC's on, air is being recirculated. Think about an airplane. Yeah, that's very close quarters, tight quarters, air is being recirculated. But a negative pressure room that should be used with an airborne precaution patient doesn't circulate the air, it removes the air from the room and vents the air in here out through special filters and then outside, but not to allow that air to recirculate. Also, while I'm thinking about it, especially true here, but this is true for any isolation room, the door should always be kept closed. You have to open it to enter, but when you enter, go ahead and close the door. Keep the door closed. There could be some additional protection for very highly immunocompromised patients. Patients with stem cell transplants, you may see some other additional special precautions being placed with them. Again, I don't care that you know all the details here, but part of it with this, they're not even allowed to have flowers or potted plants in their room because of the potential risk of fungal spores. Now, there are fungal lung diseases. Fungus in our lung, growing in our lung, yes, there is such a thing. We, however, most healthy individuals have such a high resistance and immunity, we don't get sick when we're exposed to a fungus, at least our lungs anyways. But with these highly immunocompromised patients, they have the potential. And so we'll talk about fungal lung diseases down the road, but this is in addition to some of these other precautions we've talked about. Cystic fibrosis patients, again, that's a pretty good sized patient population. CF is there. There's not nearly as many CF patients as, say, asthma patients or COPD patients, but cystic fibrosis patients have extremely thick mucus. It's very difficult for them to cough and clear secretions. Every single day they're doing some sort of bronchial hygiene to help them mobilize and remove mucus and remove secretions. But the risk for them is because they can potentially have retained mucus, they're at greater risk for developing respiratory infections and pneumonias.
Don't they use like a vest to like shake out?
They can. Again, just to kind of help loosen that mucus. So it makes it easier for them to cough and expectorate. But if we have CF patients, because they are at higher risk for developing respiratory infections, they should be kind of separate and isolated. Similar to, and this chapter doesn't mention it, God bless you, but even like a cancer patient, they should kind of be kept separate from the rest of the patient population because they're just so higher risk to get sick. Sometimes, unfortunately, these sick patients that we would rather just kind of keep in their isolation room and keep them under that protection, sometimes they have to go on a transport. They have to go to another facility. They have to go to another floor to maybe have a scan or an x-ray or something done. So we try to avoid it if we can, because we don't want that patient to be either one spreading infection or being so vulnerable that they could receive infection. So sometimes you may notice and you'll wonder, you ask yourself as they're pushing this patient down the hall, why is the patient wearing a mask and gown and that sort of thing? Again, to protect that patient from one spreading infection or for that patient to acquire an infection when they've left their room. All right, medical devices and bundles. So a large percentage of hospital or healthcare acquired infections are related to devices. The ventilator that we use, that's a big one for us, probably the biggest one for us. VAP, ventilator associated pneumonia. Patients who are on ventilators are more likely to develop a pneumonia, a nosocomial pneumonia, a nosocomial infection by being placed on the ventilator. And so we already know that going into it, that patient's at greater risk. So is there some things that we can be done to try to prevent those patients from developing a ventilator-associated or acquired pneumonia? There's some others, catheters that are in the bloodstream or catheters used for urine output. Those too, again, could be seen as increasing healthcare or hospital acquired infections. Again, specifically related to having those devices. So these prevention bundles are a package or a group of things that we can do that are called evidence-based. They are proven to work. That if we have a patient on a ventilator, or you have a patient with a urinary catheter or a central line into them, there are certain things that can be done that are proven, that are evidence-based, that can be done to lessen the likelihood of them developing a nosocomial infection. Of course, I'm going to pick the ventilator one because that pertains to us. Now, some of this stuff we're not going to understand or know just yet, and that's okay. I'm not going to ask you test questions specific from this. Just understand, if we have a ventilator patient, there's certain things that we know we should be doing for them or to them to prevent the risk of a VAP, ventilator-associated pneumonia. Early mobilization of the patient. The sooner we can get that patient up and moving, the less likelihood they would develop a VAP. Keeping the head of the bed elevated. You may think, well, isn't that kind of normal? Not necessarily. Some patients, we lie them flat. We used to lie a vent patient flat. But what we found is those patients who were lying flat, as opposed to up at a 30 or 45 degree angle, those patients who were lying flat more likely developed a ventilator-associated pneumonia. Routine mouth care with toothbrushing. All right? If a patient's going to be intubated on the ventilator for long periods of time and nobody brushes their teeth, nobody does any sort of oral hygiene, what's going to begin to form on their teeth and the grooves between their teeth? Bacteria. Again, take the patient lying flat. That bacteria starts to grow here. It's in their oral secretions. Those oral secretions fall back and somehow find their way into the trachea, which find their way into the lung. There's your pneumonia. And what ultimately led to it? Because they were on the ventilator. We lied them flat, and nobody did oral hygiene or mouth care. So there's some things we learned. Raise the head of the bed up. Make sure we're doing routine teeth brushing, oral care of the patient so bacteria cannot form or develop. There's a few other things. We'll get to some of these things down the road. Another one here I will point out, we used to change a ventilator circuit, so the circuit that connects the ventilator to the patient's breathing tube. Every day, routinely, we used to replace those circuits. Take the old one, throw them away, put a new one. Every single day we would change those circuits. You know, the incidence of VAP was higher when we did that, as opposed to we just leave it alone. We don't replace it, we don't change it.
It's a closed circuit.
Closed circuit. Anytime we break the circuit by disconnecting, we expose the patient to a variety of, potentially, of microorganisms. So that we developed, and where we're at today, keep those things closed. Do not disconnect the circuit unless we absolutely have to. I will say there's times we have to, but generally keep that circuit intact. Don't disconnect. Don't replace those circuits every single day. Now, I will say if the circuit's nasty, if there's junk on the inside, secretions or blood, we will replace it. We will replace it because we do want to still keep it clean. But other than that, we're not routinely, there's not like a schedule that we have to replace those circuits every day, or we used to step up, okay, every other day or once a week. No, only if it's visibly soiled. Other than that, leave it alone. Don't disconnect it. But again, these prevention bundles are evidence-based practices. And there's the same thing true with the urinary catheter, same thing true with a blood catheter as far as how to manage those things. All right, disinfection and sterilization, just a little bit here at the end of this chapter. So medical instruments are used in millions and millions and millions of procedures every single day. When performed correctly, cleaning, disinfection, as well as sterilization processes can reduce the risk of infection. So you're not gonna have to worry about knowing this slide, but there's certain things that we can use that would require a certain level of cleaning, disinfection, sterilization. Decontamination, just to use a very generic word here. You know, where's the item gonna go? Is it going into the patient's bloodstream or other parts of the body? And let me step back. And it's not a disposable item, so it's gonna have to be used on the next patient. Okay, that's gonna require sterilization. Maybe your surgeon's scalpel that is making the cut, that's not disposable. They're gonna reuse that scalpel on another patient on another day or time. What's gonna happen? Are you just gonna wipe that off, run it under some running water for a little bit? It's gonna require sterilization. If it's something that directly or indirectly contacts mucous membranes, again, some of these things are disposable, so bear with me here. Oral tracheal airways, a bronchoscope. Those things will require high-level disinfection, but not necessarily sterilization. Or something that might not necessarily come in contact with the patient's mucous membranes or blood or any inside part of the body, like a face mask, a blood pressure cuff. Again, assuming these things are not disposable, that just requires some sort of low-level disinfection before being used on the next patient.
I have a question.
Yes?
And it might be for maybe later, but so like obviously the respirator machines, ventilators.
Ventilators.
Yes.
There you go.
Obviously these equipment, they have filters.
Mm-hmm.
I'm assuming they should be replaced.
The filters.
Yes.
Yes.
With new use.
Correct. And new circuitry and everything else, yeah. Because most all that stuff is disposable. With the exception of the ventilator machine itself, which still will get cleaned and wiped down and processed, but that's not, the machine isn't going inside the patient. I know the air it's creating or the breath it's creating ultimately is, but it is going, like you said, it is going through special filters and things like that. And there, just so you know about the ventilators, there's what's going out to the patient location and what's coming back in from the patient, which is not the same. So it's not going the same route. Cleaning, first step in all equipment processing or equipment decontamination, involves removing dirt and organic material first. If we don't clean and we do a higher level care is not going to be as effective if we didn't clean the item first. So soaps, detergents, things to wipe and clean things up. You can read about non-critical items. Of course, those must be thoroughly cleaned and disinfected before the use of another patient. But the last bullet point here, the dirty versus clean areas. You guys will be visiting the hospital soon. You'll be visiting the respiratory departments very soon. Every department layout is slightly different, right? Different sizes, different locations. But I do want to point out something that you may experience, maybe your first time at the hospital or maybe at some point this semester. Inside the respiratory department, there is going to be what we'll call a clean area. It's where all the equipment is kept, right? Even the disposable equipment. And they're in their special packages already. There's going to be that clean area where the ventilators that are ready to go upstairs, to go on a patient, they're all there waiting to be used or to be taken. probably adjacent to that room, there's gonna be another room. Probably not gonna be as big or not gonna look as fancy as the equipment room. The clean room, there's gonna be a dirty room. That things that are not disposable, which again, respiratory department, think about the ventilators are gonna be reused. So the ventilators, before they're brought to the clean room, are gonna be on that dirty side, in that dirty room. And the reason I mention it to you guys is I could see this happening to somebody, whether it's this semester or next semester. One of the respiratory therapists asked you, because they know you're gonna be walking down to the department, hey, would you take this ventilator down for me and just drop it off there? And it had been on a patient, right? So it needs to be cleaned and processed before it can be used on another patient. So you're gonna take that ventilator down to the department. Are you gonna take that dirty ventilator into the clean area? Absolutely not. Because the clean area needs to stay the clean area. The second you introduce something that's not clean, God bless you, you just contaminated that room, right? So that piece of equipment that needs to be processed first will go to the dirty area first. And so that's the area you can drop it off in, leave it in there, the dirty side. Because somebody's responsibility will be to clean it, process it, move it over to the clean side once it's been properly processed. Okay, so, and those rooms are typically right next door to each other. Sometimes there's a hallway kind of separating them. Sometimes there's a doorway, a closed door that you can open to move things from one side to the other.
The hospital I work at, what they do is, since there's not like a specific dirty room for the equipment, there's like a sold holding for like trash and linen and stuff like that. They'll just clean it outside,
Gotcha,
outside
yeah.
the room.
But there's a designated area for
Yeah.
clean versus dirty.
Right, yeah, they'll wipe it out before they even
Yeah.
bring it to the
Yep.
clean holding.
Absolutely. All right, disinfection. Disinfection destroys. So know what disinfection does. Disinfection destroys the vegetative form of all pathogens except spores. Disinfection will kill everything except spores. Now there are certain disinfectants that if you allow the equipment to stay in contact with that for a long enough time, and what I mean by long enough time could be a few hours, it might be able to kill everything. They refer to those as kind of chemical sterilants. There's different ways to provide disinfection, chemicals, even physical methods. I'm not getting into all pasteurization, all that other stuff right now, but just understand there's different ways that we can disinfect equipment. Reusable equipment, which again, there's not a lot of reusable equipment that we use in respiratory care. Everything is disposable. But can you only imagine the time where things weren't disposable and they did have to be reused for the next person? Who did that stuff? That was part of our job, to have to be able to process that stuff. All right, sterilization. So difference between disinfection versus sterilization. Sterilization kills everything, including those spores that disinfection could not. All right, so sterilization kills everything. Again, different physical or chemical ways to do that. Again, we're not getting into all that right now. But anything that's coming in contact with the body tissues or body fluids, those items must be sterilized. So again, think of your surgeon's scalpel that's gonna be cutting one patient and then gonna be used later on another patient. Yes, that scalpel has to be sterilized before it's gonna be used on someone else or a different patient. All right, equipment handling procedures. How was I going with this one? A lot of what we use, there is a risk that if those items become contaminated, that those items could easily spread infection to another individual or a patient. You know, again, with the usage of disposable equipment, the likelihood of that is definitely remote or definitely small. But we'll talk about things in time. Again, because remember, we do things where we create aerosols, medicines, things like that the patient's going to inhale. If I don't follow the proper way to do those things, I can easily contaminate the device and introduce now a contaminated aerosol to my patient. That they're doing what? They're inhaling down into their lungs. All right, so an important alternative to reprocessing equipment is using, again, disposable equipment. Disposable equipment's great, because it's a one and done thing. Once we're finished with it, we throw it away, never to be used on anybody else ever again. Sometimes we may go through several things. Again, we tried this, and you guys, I know Tuesday you guys were talking about some of the oxygen devices. Just think about every one of those devices you guys learned on Tuesday. I tried one for this patient and it didn't work. It wasn't working right. It wasn't providing enough oxygen, let's just say, for my patient. So I went to the next best thing. I tried that. That didn't, 5 minutes in, yeah, that's not working. Let me try something else. I can go through all that stuff sometimes until I find the one that works best. What am I gonna do with all this wasted equipment? Right? You're gonna throw it in the trash. It's all disposable. It's all disposable. Don't think you're gonna put it back in the package and they didn't wear it for very long. No, that's trash. That's trash. Picture if it was you're the next patient. You're gonna put that on your face? You're gonna stick that up your nose? Of course not. So get rid of it.
Would you maybe keep it in the room in case?
You could.
In case, like,
you
they-
could
they
if there was
don't
something
need-
that, hey, we may need this later. So to just,
it
all I did was open the package and realize, we're not gonna use this. Yeah, I'll probably put it in a little treatment bag and just set it there in the patient's room in case we need it later. But generally, again, disposable, a one and done use type thing. 3 major issues in using disposable devices. Number 1, cost. So some folks may say this, well, I can appreciate the disposable equipment, just throwing it away, but wouldn't it be cheaper in the long run to just reuse the same equipment as long as we clean and process it carefully before the next person? Shouldn't that help save some money? It's possible. So cost is involved to decide, should we just keep cleaning it and reusing it, or should we just use a disposable one and throw it away each and every time? I'll give you an example. We used to, with those bronchoscopes, those scopes that can go down and look at the lung, most of the time those scopes are non-disposable. So we reprocess them after a patient's use for the next patient. They may have to go soak in a certain type of solution for X number of hours to make sure it's completely disinfected and ready for use on the next patient. And part of that reason was cost. Those scopes were so expensive. Well, today, they're still those exact same scopes. But today, they even make disposable bronchoscopes. Now, don't ask me the cost comparison, because I don't know off the top of my head. But a disposable bronchoscope that can be used for a patient, you can go down, look, see the airway, and when you're done, you can actually throw the scope away. Because they were able to bring the cost for the disposable scopes down low enough to make it worth the hospital's while instead of, and I'm just making these numbers up, so don't take these for truth. If a bronchoscope cost $5,000, let's just hypothetically say, but a disposable one cost $100, okay, so instead of having to keep reprocessing, keep cleaning it, and then the chemicals that we would have to clean with, well, how expensive are those? Maybe in the long run, now we could talk risk of infection is going to be less if we throw the scope away. Maybe that's a reason in that example that you should transition to, maybe for a bronchoscope anyways, the disposable bronchoscope. If it can do the exact same thing the non-disposable one can, and you're saving money long run and less likely for the patient to develop a nosocomial infection, then yes, we should go. And again, that's all related to cost. Now here's the thing that is my issue. Quality. Sometimes the disposable stuff, trash, right? It's garbage. In the hospital, we'll switch from one brand of equipment to another brand of equipment. And I know exactly what happened. You open that mask up, and that mask, you could just feel it. It is not the same as the one we used to use. But the hospital wants to save what?
Money.
The hospital's looking to save money, so they're going to find, okay,
Cheaper
they found the
brand.
best deal on these masks. They can give us these masks for half the cost of what they spent before, but the quality is so poor. They're going to hear it from us, the staff, and hopefully at some point we'll go back to the original. But again, I understand why they're doing it. It goes back to cost, but does it really hurt quality of the equipment? And then the reuse part, we kind of mentioned that already, having to reprocess the equipment that may be necessary to reprocess, the chemicals that may be necessary to be purchased to be reprocessed. That's an example. Fluid and medication precautions. So, I'll share this with you guys. Now, albuterol is one of our most commonly administered aerosol mints. Okay? Albuterol comes in a MDI, meter dose inhaler form. It comes in a nebulized form. Now, that nebulized form, that albuterol comes as a liquid, and we put that liquid inside of a nebulizer cup to then administer to a patient. Well, they make albuterol in these bottles. This particular one contains 20 mLs of liquid albuterol. Comes with a dropper, and so when I need to draw up a certain amount of albuterol, I can do that with this medication dropper and squeeze that dropper into the nebulizer and administer that medication to my patient. When I'm finished with treating that patient, I can take my liquid back with me, because I'm not giving it to the patient. They just took a little bit of that medication, and now I have that to use on the next patient, and the next patient, and the next patient, and the next patient. When I first started in respiratory care, that's what we used. Well, what did we find out that we did by reusing this bottle? Again, this patient is getting a certain amount of this medication, this other patient's getting another certain amount of this medication. They're not sharing the drops of medication. But what do you think was happening
Were you carrying
when
it
we
into
used
the
these
room, though?
droppers? If I have a pen, cross-contamination. If you pretend my pen is a dropper, and so I draw up a certain amount of that liquid solution, and I get the patient's nebulizer cup, and I sat there and I dropped those few drops of medication, who's to say that this part didn't touch the nebulizer cup? And then, okay, we gave the patient that medication, I put this back inside this bottle, sealed it up, tightened it up, again, but the outside of this dropper touched my patient's nebulizer, and I'm on to the next patient, and the next patient, and the next patient, and I do the same thing with every one. That cross-contamination affecting multiple patients. So I hate to say it, that when I first started, I was probably one of those people contributing to the spread of nosocomial infections through the nebulizers that the patients were receiving to get their breathing medication so they would feel better, open up their airway so they could breathe easier, and I'm potentially spreading cross-contamination from the first floor to the second floor to the third floor and so forth. Today, and these things still do exist, but not for us really to use in the hospital setting, patient to patient to patient to patient. What we have now is what we call unit dose vials. This is albuterol that's inside this vial. When I'm ready to administer it, I simply twist the top off and I squeeze the contents of this vial into, say, a patient's nebulizer. I throw the vial away. I give the patient the medication. When it's time for the next patient, I get a whole nother one of these and administer their medication that way. So something like this, instead of reusing this, each person has their own individual unit dose vial. And there's already, I don't have to worry about trying to measure and be exact. And do you think there's times, oh, I'm supposed to get 0.5, but really it's a little up here, or really it's a little under here? How inaccurate of me administering that medication when it's supposed to be exact. The exact amount is in here. As long as I squeeze the contents of this inside that nebulizer cup, the patient's getting that dose of medication. Last thing here, surveillance. So this is the ongoing process of monitoring patients and personnel, including students, for acquisition of infection, colonization of pathogens, or both. These infectious control and prevention committees and panels, I mean, that is one of their duties and roles is to make sure us as a staff, us as a hospital, us as an ICU or ER or floor or unit are all practicing the policies as they are written. Because they can make the policies say whatever they want, but if none of us do it that way, then how are they knowing that they're preventing the spread of any potential infection? So sometimes it creates competition amongst a hospital itself, that you may see things published from the infection prevention committees that the third floor such and such has a 0% VAP rate, but the fifth floor such and such has a 10% VAP rate. again, is trying to, hats off to the folks on the other floor that have 0 ventilator-associated pneumonias versus someone else that has higher. Or a unit that leads the hospital in the lowest percentage of nosocomial infections, because everybody there is doing a really, really good job as far as infection prevention, hand hygiene, et cetera, all right? So those things are constantly being monitored and measured, even to the point, and you may think when you're a student in the hospital that you're anonymous, that nobody knows who you are, nobody knows who you're with. You'd be shocked and amazed that you're gonna walk into a nurse's station, you're gonna walk into a unit, and there's gonna be people all over the place. There are crowded places. Staff members from all over the place, different practitioners from a variety of different healthcare fields. But somebody sitting there, their role today is to make sure everybody that enters a room is doing proper hand hygiene. You won't know who that person is. You won't know that's what they're doing. That's just somebody just kind of sitting there along with everybody else who's sitting around. People are moving and documenting and charting and doing this and that. And it's somebody's role to watch and make sure that everybody who's going in and out of this patient who's in an isolation room is wearing the gown like they're supposed to, or wearing gloves like they're supposed to, doing hand hygiene, coming and going.
So like
and they will document that stuff.
At Mayo, they have literal surveillance cameras that
Yeah,
are specifically.
absolutely. Like I said, somebody's always watching to see, are you doing it?
And they
They'll
will
know if
call
I'm in
you.
this room and didn't put the gown on.
They know who you are walking through into the patient room.
Absolutely.
They'll call you on your rover and be like,
Right, now you guys won't be wearing those things, but somebody will come down and say, hey, your respiratory students are not doing this or that. All right, so make sure you're following those guidelines. And if you're unsure, ask. You know, I don't expect everybody to be perfect their first go around clinically, but if you see a patient under isolation precautions, hey, red flag, there's gonna be a sign on the door. There's gonna be a card outside the door. That should be your first thing that you see or notice before you even get the chance to enter the room. All right, questions? Yes, sir.
So,
As long as it's not about tuberculosis. I'm just teasing.
Is there ever an instance where a patient would come from like a nursing home or something on a ventilator or like, you know, on a breathing tube? Do
Yeah.
you guys change it out at the hospital to make sure that they didn't come
Yes.
to the hospital or something?
Correct. So someone that's being transferred in, say, that's on a ventilator, that ventilator they're on at that facility probably stays at that facility. So they may be using the bag valve mask type resuscitator or a smaller portable ventilator that stays with that ambulance team that's transporting the patient. So that stuff usually doesn't come along with the patient. We have our own. We know they're coming, we get report on that patient. If they're coming to our ER, we're ready to pick them up, and they'll be attached to one of our ventilators with our circuits to kind of get them started anyways.
Sorry, clean.
Yep,
Right.
yep. Yeah, that we open brand new out of the package.
So back to the surveillance thing, it's crazy how like serious that is because it makes me think about why my manager gives us our badges at work, because it counts the times that we're going in and out.
Yes, yeah. Technology is great.
And then-
Technology is amazing, but technology is also watching us.
Some says like, please phone in or whatever, and then
What
others
does that
say
mean?
like, hand wash only. So I guess they are like looking at the numbers.
Right. Yeah, they are, because that is someone's role. That is somebody's job to make sure we're doing what we're supposed to be doing. Because ultimately, trying to do what with these healthcare associated infections, keeping them as low as possible. Even though studies say it's 4%, you may think 4% is not that many people, right? Shouldn't be too many, but if you think of the, I'm guessing millions of potential hospitalized patients, 4% of that, millions is a big number. And so, if we, again, try to prevent nosocomial infections, because if someone develops a nosocomial infection, remember, that's in addition to whatever the reason was they came to the hospital in the first place. That's gonna only hurt their chances of a positive outcome, a successful outcome of being in the hospital. You know, you come into the hospital with a stubbed toe, and while you're there, you develop a horrible pneumonia. You know, now you're on the ventilator with pneumonia, but you came there because you nearly broke your toe. But now that you were there, that's where all the bugs are, and now you've got a nosocomial infection. So trying to keep the nosocomial infections, hospital-associated infections, down to a minimum. Because people always say, are these things preventable? nosocomial infections, are they preventable? Yes, they are preventable, but it takes all of us to participate. Just picture, let's say we're the hospital, we're the respiratory department, and I'm the one who never washes his hands, never puts the mask on when I'm supposed to put the mask on, but everybody else does everything perfect. I'm the rogue agent here, and no wonder our infection rates are up. Because when I'm not working, the numbers go down. But when I'm on board, my weekend, here comes all the infectious agents because I'm not doing what I'm supposed to. And all it takes, the weakest link. All it takes is that one person not practicing what they're supposed to do. Hopefully I didn't create a room full of germaphobes. That was never my intention. But just to be aware and be mindful. All right, so my question, sorry, forgot about this one. Quick addition today. So last thing here, so should you use a hospital bathroom? You're gonna be there long enough, I would hope so. Or you're wearing Depends or something, right? All right, so I apologize for the audio. It didn't work didn't work well enough for me anyways. When I sent this video through the speakers that are in the room, so the speakers that I have turned up kind of loud are the ones on my computer right here. So you'll be able to hear it, it's just not coming out of the speakers that normally are in the room. So the thing is, should you use a hospital bathroom?
I have to go to the bathroom and no one will take me home. What's wrong with the bathroom here? Pneumococcus, streptococcus, staphylococcus, and other assorted caucuses. Sheldon, my mother is on her deathbed, and my fiance is grief-stricken over putting her there. I'm not taking you home. Will you at least go with me to the restroom here so you can open the door and flush the urinal? No! This might be a good time to point out, Howard, that friendship requires a certain give and take. Hold the door! Mr. Wallowitz? Finally. What fresh hell is this? You can't leave him, you've been exposed! Don't hurt him. It's all good.
All right, so my question's for you guys. Sorry, I love that scene. All right, approximately what percentage of all hospitalized patients will develop a healthcare associated infection? 4%. 4%. First question was B, 4%. Next question, if a patient has tuberculosis, what type of isolation precautions should the patient be placed in? Contact isolation, droplet isolation, airborne isolation, or TB isolation? This one is C, airborne isolation. Tuberculosis is spread. Small particles stay suspended in the air for a long time. It's not like droplet where they sit there and just go and fall. So TB stays in the air for a long, long time. And D I made up. There's no such thing as TB isolation, even though it sounds kind of good, right? That's why be careful, because I will make on your test wrong answers that sound kind of good, but if you think about it, never appeared in the books, or we never said those words in here, right? But it sounds kind of good, but it's not. But obviously D is not the right answer. So airborne, because there's only 3 isolation precautions, right? Contact, droplet, airborne. All right, next question. What type of processing technique would be used to destroy vegetative forms of all pathogens with the exception of bacterial spores? That is disinfection. That is disinfection. As opposed to sterilization. Sterilization kills everything, including spores. All right, so this answer was disinfection.
Clearly D.
All right, any questions? That was actually my last question, sorry. Only giving you 3 today, only giving you 3. So just as a reminder, Monday's a test.